Hi, welcome to this segment on kidney health. With me, Dr. Vinod Kumar, senior nephrologist and a transplant physician with a 15 years of experience. He is presently working in Manipal Hospital, Kanakpura Road. So, welcome to this show. And he's my friend. And we ask questions on behalf of public, what people commonly have in their minds, and people always keep searching on the Google. And some questions in favor of GPs, general practitioners, who commonly miss something or don't think it's important. So, first segment of this interview is about general awareness and early detection. So, let's start the questions. So, why is kidney disease are not diagnosed until it is late?
Yeah. See, the prevalence of chronic kidney disease or kidney disease as a whole in the world, it is as high as 10%. Whereas in India, various recent literature has mentioned that it is between 13 to 17%, which amounts to 15%, which is a huge number.
Okay.
Lack of awareness is one of the most important thing where the kidney diseases have gone silent.
Okay.
See, unlike cardiac issues, with the death of various celebrities, people are more worried in getting ECG, echo, TMT, CT angiogram. But same is not true with the kidney diseases.
So you mean to say somebody suddenly die of cardiac arrest, that panicness, fear is there.
Correct.
People take early intervention of a TMT and echo.
Correct.
But in kidney diseases, there's nothing like sudden.
See, frankly speaking, a few simple tests is more than enough to diagnose a kidney disease. A simple urine routine as well as creatinine. These are the two main tests which is required to diagnose a kidney disease. If this is abnormal, you can get an ultrasound abdomen. These three tests are enough to say whether you have a kidney disease or not. But people are not that aware to undergo these few simple tests.
So, what are the early signs and symptoms often people ignore about kidney disease?
See, your first question, why this is diagnosed late? So, similar to cancer, most of the symptoms are not evident in patients with kidney disease, like chronic kidney disease. It often comes late, except in few cases of diabetic kidney disease, where they will manifest with the swelling of the legs. 80% of the patients with kidney disease may not have any symptoms in the early stages. Only when you do a blood test, you will.
Because this I commonly observe, many people come to the consultation when they have a swelling in the feet, they are more worried whether they have a kidney or liver issues. If the dose swelling is there, even if they're having high proteinuria, they don't have any symptoms.
So that's what. As far as the symptoms is concerned, subtle edema, edema more during traveling. If you see any edema in the feet, that is swelling of the legs, you should get yourself tested for kidneys, liver, and heart. So this is one of the subtle symptom or sign which you detect. That is one. Second, blood pressure. See, blood pressure with age it is okay, but if the blood pressure is getting uncontrolled and your requirement of BP medicines is going up, that is one of the sign to look for kidneys. Third, in a diabetic patients, see you are taking some medicines and sugar is fairly under control, but at some point of time with the same medications, if sugars are coming down, that is hypoglycemic episodes is one of the sign where you should look for kidneys. The reason is with the onset of kidney disease, the insulin excretion from the kidneys comes down, so it gets accumulated in the body, and the requirement of anti-diabetic medications automatically come down. So hypoglycemic episodes is one of the early sign for kidney disease. That is when you should look for creatinine and all this.
So, if you say it is not only the swelling of the legs, it is sometimes sudden increase in the BP requiring more medications, and suddenly started getting low sugars, then it's early sign that you should check the sugars.
Correct. Only in the later stages you will get decreased appetite, nausea, vomiting, generalized itching of the body, dry skin, lack of concentration, impaired memory. Only in the later stages the swelling will increase. You will have breathing difficulty on walking, and
So
more
you
you
say
will
early kidney disease, there is no swelling of the legs. This has to be remembered. patient
In
has
majority of the
majority
cases, in
symptoms.
majority of the
In
cases.
early stages, there is no swelling. Only the late stages, there is a swelling. And
The only way to detect is to keep checking your kidney function test periodically.
so periodically means that how, for example, diabetic hypertension.
Yeah.
How often they should get this? Say, for example, we order HbA1c once in 3 months. It is good to check this kidney function also along with HbA1c.
See, any diabetic and hypertensive are at risk for kidney disease. It is said that if the kidney functions are normal, you need to monitor this annually, that is once a year. You need to have your eye checkup and kidney checkup. What you will do, you will just get a urine albumin creatinine ratio as well as creatinine. But if there is an onset of kidney disease in this group of patients, it is better to periodically monitor it every 3 months. As you said, along with HbA1c, it is better to.
So at least the high risk people at least once in 3 months. Correct. So nowadays common people keep on asking. So as a kidney specialist, what is the recommended intake of water per day to keep your kidneys healthy?
Yeah, see, usual recommendation of water intake is somewhere between 2 to 3 liters, that is around 2.5 liters is more than enough. Having said that, is the more water intake harmful to the kidneys? Not really, but there are certain other conditions like water intoxication, sometimes called as psychogenic polydipsia, where people drink more water. Those things can put pressure onto the kidneys, one, but more than that, it causes some kind of electrolyte disturbances rather than a direct effect on the kidney damage. That is in normal individuals which I am talking. But whereas with patients with kidney disease, especially chronic kidney disease, majority of the individuals, nearly 80% of the individuals will retain salt and water. In those individuals, you need to restrict water intake. How much? Say average of 1.5 liters, that is 6 glasses of water. But that can be titrated based on the swelling of the feet or breathing difficulty. You can either decrease or increase. In 10 to 20% of the patients, till the last stages, the urine output is well preserved. In those group of patients, we can be flexible.
So some people keep telling, I drink 3 liters of water per day, 5 liters of water per day. So drinking more water, can it put more pressure on the kidneys?
Yeah, see, that is what I mentioned. Until unless, see, up to 3 to 5 liters, it should not be a big issue. See, people who exert physically more would probably require more. What I am exactly talking is, there are certain conditions like psychogenic conditions where people are obsessed with drinking more. In those group of patients, rather than direct kidney damage, definitely it will increase the load, but kidney has got a wide capacity to accommodate more. If it is done on a chronic basis, there can be some electrolyte disturbances rather than direct.
If you drink too much water also, some could be electrolyte disturbances. Yeah. And one common question for the public, many people are not aware the difference between a nephrologist and a urologist. So all these people search on Google, many people. So you can tell me, to the audience, what is the common difference and when should consult a nephrologist, when to consult a urologist?
Yeah. See, basically, nephrologist deals with the kidney, its function, whenever there is a breach in the kidney function. For example, if there is any protein leak in the urine because of kidney injury, or if there is any blood leak in the urine, or when there is elevated urea, creatinine, these are the conditions where you should seek a help of the nephrologist. Whereas urologist deals with kidney and urinary tract, but in the kidneys, majorly they deals with whenever there is a stone in the kidneys, or tumor in the kidneys, or any bladder issues. These are the conditions where urologists come into the picture. See, whenever there is a drop in the function of the kidneys, you should seek a nephrologist opinion. Whenever there is protein leak in the urine or blood leak in the urine, you should seek a nephrologist opinion.
So in other ways, urologists are surgeons. They do operations for a kidney stones and any probability to the urinary tract. Nephrologists are like kidney physicians. They deal with all the medical problems, but they also engage in dialysis initiation planning and also in any transplants as a physicians. But nephrologists don't do surgeries, urologists will do surgeries. This is for the common understanding. So with this, we'll go to the second segment. So we'll go to the second segment. This is regarding how diabetes and hypertension affect the kidneys. So first question is, how do diabetes and hypertension damage the kidneys in a simple language for the people to understand?
Okay. It is a big subject. To not to go into the pathophysiology, what we call. Excess sugar causes direct toxicity inside the kidneys. That is called as glucotoxicity. That is one. Second, it releases various free radicals, which causes oxidative stress, and that can cause damage to the kidneys. And it also increases the pressure inside the kidney, both blood pressure and diabetes. It is called as hyperfiltration injury. So these are few mechanisms which can cause damage to the kidneys over a period of time. More so in patients who are having uncontrolled sugars and uncontrolled blood pressures are more prone.
So in common terms, high BP, high sugars definitely spoil your kidneys.
60 to 70% of kidney diseases are contributed by diabetes and hypertension.
So common myth is like sugar is related to diabetes and salt is related to BP. So which is most dangerous, sugar or salt?
See, the most common among these two, the most common cause for kidney disease is sugar, diabetes.
So many people think that salt is always the culprit. It's not so. Your sugar is more dangerous than a salt because body can still handle more salt, but body cannot handle too much sugar because diabetes itself can lead to insulin resistant and other things. So many times when they do the annual checkups, no, the people come with a Tata 1mg and other albumin forms. There is some mild albumin created protein in the urine. Many times we recognize, many times GPs recognize, but people often ignore that. So, what is your take on that? What people should do at that time, in the very initial stages?
Okay. See, this urine microalbumin, which we were mentioning it as earlier, the terminology has changed. What we usually do is urine albumin creatinine ratio. The same name, microalbumin creatinine ratio, still holds good in many of the labs. See, microalbumin means a small amount of albumin leak, that is between 30 to 300 milligram, which earlier test was not detecting, only after 300 it was detecting. So 30 to 300 milligram per gram of creatinine albumin leak in the urine indicates that there is early kidney damage. This is applicable to the patients with risk factors like diabetes, hypertension, heart failure. These are all the risk factors. Having said that, one value of albumin creatinine ratio being in this range should not be worried, especially in normal individuals, because this is affected by various other factors like excessive stress, like if the urine is concentrated, if you are having fever, like if you have done the test immediately after the exercise, this can be falsely high. So it is always better to repeat a test, taking care of all these factors into consideration. But people with risk factors, definitely you should keep an eye on this. This stage, that is early stage of microalbuminuria, what we call, if you tackle the risk factors at this stage to a greater extent, you can reverse the process. Once you cross this stage, then it is a progressive course.
So what is the exact test that you mentioned? Albumin creatinine ratio or microalbumin?
No, it is always urine albumin creatinine ratio.
That's the proper test.
Correct. Because it is always given importance along with per gram of creatinine, because this can vary. So per gram of creatinine is the value which is more important. Between 30 to 300 indicates microalbuminuria. More than 300 milligram, it is overt albuminuria. That is.
So what the common thing is, many people have some protein in the urine, but the kidney function is normal. This is where they don't bother and they don't have any symptoms. So you mean to say any protein leakage is abnormal, any protein in the urine is not normal, except in the some of infections. So it has to be taken care. And how often you suggest to do urine albumin creatinine ratio for a diabetic and hypertensive people?
Yeah, see, that is what initially I mentioned. If it is normal, then annual screening, that is every year. If it becomes abnormal, then every 3 months it is better to monitor it.
Okay, this is about diabetic. We'll move on to the next segment. We'll go to the third segment. This segment is about tests and how we have to monitor the kidney functions and what are the screening tests for the kidney. Yeah, we'll come to the common test now. So common test we do in routine checkups is about one creatinine, sodium, potassium, and eGFR. So what are the minimum screening tests anybody above 35-40 years should do once in a year? And I think most of them are covered in the annual health checkups. And how to interpret them in as a common man.
Yeah, see, as I told you earlier, 3 tests. One is urine routine. You can do first a urine routine. Urine routine will give you wealth of information. If there is evidence of any protein leak in that, you can go for urine albumin creatinine ratio. Or if the patient is having risk factors, straight away go for urine albumin creatinine ratio. That is one. Regarding the renal function test, what we say, it includes blood urea nitrogen, and creatinine. Among these three, creatinine is a more reliable marker because it is released at a steady state. It is not reabsorbed or secreted in the kidneys. So this is more reliable marker, and it is a surrogate marker to calculate eGFR. So what is GFR? That is the most common question what people ask.
Because most of the health checkups now, 1 mg or other thing, no, they have eGFR, some variation, people get panic.
Correct. See, GFR means glomerular filtration rate. It is a better marker when compared to that of creatinine. We don't have any other marker to detect early kidney disease, but among this, GFR is a better kidney marker. Why is it so? Because creatinine is affected by age of the individual, gender of the individual, body mass or muscle mass of the individual. Earlier, race was given into consideration to calculate the GFR, but now that is discouraged. Whereas GFR will take all into consideration and give a standardized value. GFR is not done in the lab, it is a measured value in the sense like if you have a creatinine, you feed the age of the individual, creatinine, gender of the individual, you will get a GFR value. Okay.
So what is the normal range of GFR?
Correct. See, normally it is between 90 to 120. Average, we will take it as 100. So, suppose if the GFR is 50, what does that indicate? It indicates that 50% of your kidney is damaged, only 50% of the kidney is working.
So, common scenario what I encounter is many young people who have no comorbidities, no risk factors. So, GFR comes slightly less. Maybe you told 90 to 90 and above is good, it is 80. So, what to do at that time?
See, in normal individuals, this measurement of GFR has got a fallacy. Okay.
Yes.
So
important point.
Correct. So it is more applicable in patients with already pre-existing kidney disease. That is, creatinine has started elevating. To monitor the GFR and to stage the chronic kidney disease, it is more effective. Having said that, people need not have to panic if the GFR comes to somewhere around 80 to 90. More than 60 without risk factors, you need to just closely monitor it. And single value of GFR, you should not be worried because it is dependent on creatinine, and creatinine varies with your hydration status, protein intake, and muscle mass. Again, like your question of like elderly individuals, especially elderly women and all, where the muscle mass is less, the creatinine is falsely less, and their GFR can be falsely high. Whereas a young adult who is a gym goer with the muscle mass is more, where the creatinine is slightly on the higher side, GFR can be falsely mentioned as low.
So here, in the elderly people with the less muscle mass, even the creatinine is misleading.
Correct.
Okay, in such cases, how to know the kidney is functioning normal or not? One is eGFR. Any other test like cystatin C?
Cystatin C can be done, which is a more specific marker than when compared to creatinine, but it is not widely available or checked in the laboratories. So we are still relying on creatinine to know the kidney disease. There are other biomarkers called as urinary biomarkers which has come into the picture to detect early kidney disease, but these are all more applicable to detect acute kidney injuries.
So more or less there are three important tests. One is urine protein, urine albumin creatinine ratio, creatinine and EGFR. And the young people who have slightly less EGFR without any risk factors, so need not worry.
I would always tell them to keep a close follow-up, repeat the test. If it is consistently on the lower side, then go for further
I also seen some obese individuals, but without any diabetic hypertension, can have low GFR. Any interpretation from this?
See, GFR again, I told you it is based on age, gender, and creatinine. If by any chance, if their creatinine is slightly on the higher side, the GFR would be calculated as low. So it's always better to repeat it. That is one thing. Second, obesity itself is a risk factor for kidney disease. So we need to have a close monitoring and give them lifestyle modification advice and ask them to reduce the weight.
And our audience understanding what is the normal value of the creatinine.
Okay. See, it is the various lab has given a different range, but on an average, in a standard lab, less than 1.3 in men and less than 1.1 in females should be acceptable. But anything in the borderline range, you should always have a close watch, because creatinine will start rising only when 40 to 50% of the kidney is already damaged, then only the creatinine will start rising. So you need to keep a close watch if the creatinine is in the borderline range.
So this is very important point. This creatinine is rise only after 40% of the kidney is damaged. So before that, your creatinine is still normal. That's why measuring this urine albumin creatinine ratio and looking for any protein leak in the urine is very important test for a regular follow-ups.
Okay.
So we move to the next segment about medications, painkillers, and other thyroid related and kidney health. In this fourth segment, we'll discuss about what is the effect of painkillers and some antibiotics and then dye injections, which commonly used in CT MRIs, how it really affect the kidneys. So coming to the first questions, it's the people have a habit of taking a painkillers for any pains, like some people with a back pain, chronically taking a painkillers. So one is like, what are the common painkillers which is deadly for the kidneys, and which are the safe painkillers which can be used, and any people as a clinical experience you are seeing, people are using more painkillers, end up in a kidney problems.
See, definitely painkiller is detrimental to the kidneys. The painkiller which comes under the category of NSAIDs, which includes commonly used is diclofenac, aceclofenac, ibuprofen, mephtal, that is mefenamic acid, which is commonly used by gynec or females, nimesulide, these are naproxen. These are the group of drugs which can harm the kidneys. What dose it can harm the kidneys? There are two types, like it can be dose dependent toxicity or dose independent toxicity. Dose independent means it is causing allergy to the kidneys. It is called as idiosyncratic reaction. In that case, even one or two dose of medications can cause damage to the kidneys. But most often what we see is chronic usage of these painkillers can cause damage. It is called as chronic analgesic nephropathy. Like without their knowledge, they would be taking for some back pain or headaches. Repeated usage of these medications can cause damage to the kidneys. Safer medications are, you can take for mild pain, you can use paracetamol, which is Dolo 650 or Calpol or anything. Or you can use tramadol acetaminophen combination like Ultracet, you can use it. Suppose if you want to use NSAIDs for any reason, say if there is significant inflammation, use it for short duration, say 2 to 3 days, and change it over to a mild analgesic rather than continuing chronically on NSAIDs, which is not good for the kidneys.
So you recommend only this tramadol, paracetamol?
For mild pain, you can always use paracetamol.
Any clinical experience with you, like you have seen patient who taking painkiller for a long time for this one, ended up with very serious kidney damage?
See, these patients, which chronic painkiller abuse nephropathy won't cause much symptoms as far as edema or anything is concerned. Only when you check the creatinine values, it would be on the higher side. For some other reason, when you check it, it would be on the higher side. When you take a history, they would be taking painkillers for a longer time. So there is a definite temporal correlation between these two. We have seen many patients coming with unexplained rise in the creatinine even after 1 or 2 doses of tablets or injection. These are all idiosyncratic reaction. This is very commonly seen in practice.
The second question is like people commonly go to the pharmacist and take some antibiotic, and every time they have some infection, they go to the pharmacist and take antibiotics. And this habit is also have some effect in the kidneys, or is it okay?
See, most often people have a conception that antibiotics can cause kidney damage. Majority of the oral antibiotics are safe. Majority of the oral antibiotics are safe, except certain IV antibiotics. And when you are admitted for severe infection, certain category of antibiotics like aminoglycosides are potentially nephrotoxic. Second, like vancomycin, which can cause kidney injury. Colistin, which is used in ICU settings, that can cause kidney injury. Certain antifungals like amphotericin B, these can cause kidney injuries. By and large, oral antibiotics are generally safe.
So this is a good thing. The majority of the oral antibiotic we give in a original prescriptions are safe, but still be careful. Do not abuse repeatedly. The third thing is about the BP medications. Commonly we call it as the telmisartan. We call it ARB groups. So what happens, we have seen sometimes people are not using it a proper dosage. They're using the excess dosage more than recommended dosage. So any recommendation for the dosage and anything you have seen in clinical practice, people using excess and that led to high creatinine.
This telmisartan, olmesartan group of drugs are considered to be excellent as a kidney protective agents in the initial stages of any kind of kidney disease, both for BP control and to control the protein leak in the urine. However, whenever we are using ARB, that is these group of drugs, you should monitor two things. One is creatinine and potassium. Any 20% increase in the creatinine is acceptable, which is seen in the initial stages after starting the medications. But anything more than 30% increase in the creatinine should really raise your eyebrows. You need to look for what is called as renal artery stenosis. Usually, if there is bilateral renal artery stenosis, the creatinine can go up. It can be very detrimental. Of course, dose needs to be definitely monitored. Any high dose, especially in the presence of kidney disease, can cause life-threatening hyperkalemia. So that needs to be closely monitored. What I would recommend is the use of these group of drugs is more beneficial in significant proteinuric individuals. Rather than just mere presence of elevated creatinine, it is more useful in severely proteinuric individuals. But at the same time, even though literature supports the usage of these drugs in the later stages of kidney disease as well, but our experience says that when the GFR is less than 30, it can rapidly worsen the kidney issue. That is because there would be microvascular damage, even though there won't be any renal artery stenosis. But our group of population with diabetics will have microvascular damage, which can further potentiate the renal worsening.
So in summarizing that this ARBs, telmisartan and all, very good drugs for proteinuria, but when suddenly the creatinine is rising,
We need to keep
and these are all good drugs, but you have to use them with caution, with the advice of a doctor, and don't keep on using continuously without proper review. And second common thing is, so we are treating many patients. One patient is on oral tablet for a diabetes and some BP medications. when his creatinine is suddenly 2.5 and all, so when we convince them that some of the medication you cannot take, you have to go for a alternative medicine or sometimes only insulin, the acceptability is very poor. Then they tell doctor give only tablets, I cannot take insulin. So what do you think at what level of creatinine? So these tablets are not safe. Or which are the diabetic medicine which are safe? And what level of creatinine you can directly must go to only insulin levels?
See, one more common myth is like people will come and tell that like, sir, I am taking diabetic medications for last 10 years and I got a kidney issue. I want to confirm it. No diabetic medications can directly cause damage to the kidneys. However, we need to reduce the dose of certain medications with the onset of kidney failure. In that, one important drug is metformin. Many people blame metformin for kidney damage. It is not so. But when the GFR falls to less than 30, we may have to stop metformin, not because it will worsen the kidney failure, it causes something called as lactic acidosis. But various Indian studies recently done does not favor that concept, but still the general practice is less than 30 GFR, stop metformin. The question Dr. Vishwanath has asked, whether it is safe to continue the oral medications for a long time. See, once the kidney disease ensures, it is always better to start insulin early because you can control the dosage because the chances of hypoglycemia is very high with oral medications like long acting sulfonylureas. These things should be avoided preferably when the GFR falls to less than 30 because chances of hypoglycemia is high, but safer drugs like gliptins and all, you can try to continue, but you need to reduce the dose of gliptins to 50%.
So whenever there is a increase in the creatinine or decrease in the GFR, we have to give an alternative diabetic medication which is relatively safer in kidney, or sometimes you have to switch to the insulin. So this is the message. Second thing is, this is questions for the information for GPs. Many people know that telmisartan ARBs are good in decreasing the proteinuria. And now the lot of evidence is that even SGLT inhibitors also help in decreasing proteinuria and also cardioprotective. So your
see, beyond doubt, various trials, various studies, meta-analysis has proven that SGLT2 inhibitors is one of the revolutionary invention in the field of medicine. Of course, again, with the GFR of less than 30, we should use it with caution, preferably to avoid. Otherwise, it has got a lot of beneficial effects in controlling the hypertension, controlling the edema, controlling the sugars when it is used with other diabetic medications, and it has got a very good beneficial effect in reducing the protein leak as well.
so SGLT inhibitors can be used in even in the end-stage kidney disease.
No, that's what. Less than 30. See, there are various studies, even up to a GFR of 25, they have used and found to be beneficial. But what I would recommend is when it is less than 30, use it with caution or preferably avoid it. One more risk factor with SGLT2, especially in diabetic patients, is the risk of recurrent urinary tract infection. Make sure that if the patient is having recurrent UTI, stop it. Fungal UTIs are commonly seen, which is commonly seen nowadays.
So the common understanding is less than 30 GFR, you are supposed to stop all the tablets. Go for insulin. And
you can use gliptins at a lower dose along with insulin to have a better insulin sensitizer effect.
So there are many people who think that Ayurvedic medications are completely safe. Homeopathic medications are completely safe. So you think that all homeopathic medications are safe, or any instances in clinical practice they end up in a kidney damage by indiscriminately using these Ayurvedic medications?
See, common understanding among the general public is these are all natural and it won't cause any harm. What I say is any medicine, if it has got an effect, it has got side effect. From allopathy point of view, we usually do all studies and then only release into the market. I am not blaming all Ayurveda medicines or all homeopathy medicines, but certain Ayurveda medicines with good literature has got some heavy metals which can cause damage to the kidneys. So various herbal medicines with strong literature has shown damage to the kidneys. I am not qualified to say which Ayurveda medicine is bad or harmful to the kidneys. Same thing applies to the homeopathy as well. As far as possible, we discourage using these medications, especially in patients with kidney disease.
So the problem is some people for the kidney problem come to the nephrologist. For a diabetes control, they go to the Ayurvedic doctor. Is it good?
No, see, it is better to stick on to one thing. Again, all CKD, we discourage from using Ayurveda, certain Ayurveda medications. We do see a temporal correlation from using the medications and worsening of the kidney disease.
So it's better to stick on to one specialty.
Right.
So if you're having diabetes with hypertension with Ayurveda homeopathy and for a kidney problem and heart disease coming to the allopathy is not good. Whichever the domain specialty you prefer, you stick to that with the expert advice. One important question about this contrast agents and the kidney problems. So it routinely is, we'll do CT scan, contrast CT for abdomen, contrast MRIs, and nowadays the CT coronal angiograms. This is a common way contrast is used. So how to prevent kidney damage by using these contrast agents, and what are the precautions to be taken?
Okay. 2-3 things. One is two types of contrast. One is CT with contrast, second is MRI with contrast. MRI contrast, gadolinium is used, and CT with contrast, it is an iodinated contrast which is used. Gadolinium contrast does not cause direct damage to the kidneys, but it causes something else in patients with advanced kidney diseases, that is when the GFR is less than 30. So till the GFR is less than 30, MRI contrast, we have no issue. You can go ahead with MRI contrast. That is one. Regarding the CT with contrast, until unless it is a coronary procedures which is indicated for say abdominal procedures or for some other diagnosis, if an alternative imaging modality is available, I would prefer to do that rather than going ahead with iodinated contrast. This is for patients with kidney disease, not for normal individuals. But patients with kidney disease, the challenge comes when they have a heart disease, okay, where the coronary procedure is indicated. See, earlier days there was a huge fear, not only among the public but also among the medical fraternity regarding the use of iodinated contrast. The contrast agents are also evolved. Now there is something called as say low osmolar or isoosmolar contrast, which is less nephrotoxic. Is iodinated contrast nephrotoxic? Definitely yes, potentially nephrotoxic, but usually it causes what is called an acute kidney injury. That is a temporary form of kidney injury which will improve over a period of time. So when there is a definite indication, especially with the cardiac, see you are having a heart attack and you want to know where is the block and how to sort it out. If you don't tackle the heart, definitely it is indirectly going to affect the kidneys. So heart is very important. When the benefit is more than the risk, benefit of tackling the heart issue is more than the risk of contrast related kidney injury, definitely go ahead. If your cardiologist is saying, I am suspecting a lesion inside and it is going to be beneficial, please go ahead with the procedure. Don't be scared of undergoing a contrast exposure. So what are the precautions you can take? These things are applicable for patients with kidney disease. Two most important things what we do. One is hydration. Hydration is not oral hydration, IV hydration by simple normal saline. Prior and post procedure is what is indicated. That is one. There is something called as N-acetylcysteine when it is used along with the fluids. That is also going to add on to the benefit, which can be used for 2 to 3 days around the contrast exposure. So definite indication, please go ahead, don't hesitate. Otherwise, heart will get affected, which will indirectly affect the kidneys.
So one thing is the MRI gadolinium contrast is completely safe, no problem.
I will answer that question. See, gadolinium contrast is not kidney toxic. When it is less than 30, these contrast will get deposited underneath the skin and it causes something called as nephrogenic systemic fibrosis, which is more of a skin condition, but it can affect the systemic organs as well, which can be life-threatening. So in advanced kidney failure, so less than GFR of 30, this is usually contraindicated. But again, even in gadolinium contrast, it is evolved. Grade 2 agents, which is more safe, can still be used in selected cases.
So one common question, suppose we send for a CCT contrast or a CT coronary angiogram with the clear indications. Patient developed high creatinine post-procedure. So how to manage that?
Now that's what. Usually it will be a temporary rise.
How long
And
it takes?
usually it will take 5 to 10 days for it to resolve. So not to worry when you are done it for a definitive reason, because that is more beneficial for you rather than a temporary rise in the creatinine and form. Okay.
So it can gradually any particular hydration medications are used
So that's what I mentioned. Like this has to be used. Even see after contrast exposure, I would recommend to take good amount of fluids of say 3 to 3.5 liters for next 2 to 3 days, along with that inositol cysteine, which is available as a tablet format, which is used given in the dose of 1200 mg 2 times for 3 days.
Is there any safe limit of contrast injections which is used?
Yeah, correct. See, it is like this. Lower the better, and preferably isoosmolar or low osmolar contrast, as low as possible. See, for usual diagnostic procedures for coronary angiogram, they use 20 to 30 ml, which is more or less safer. But when they have to plan for angioplasties, they end up in using sometimes 100 to 200, which can be slightly at a higher dose. Those are the cases where there can be a rise in the creatinine. Conventional angio is relatively safe.
So what is the difference between the dose used in the normal coronary angiogram and CT coronary angiogram?
Correct. See, CT angio, we use a very higher dose because it is injected intravenously. Close to 100 ml is what is injected, which goes into the body, then lights up the coronaries. Whereas in conventional angio, it can be finished in as low as 20 to 30 ml of contrast. See, one more question what we commonly encounter is a patient on dialysis if he has to undergo a contrast exposure. Again, everybody fear about the contrast in those cases, but since the patient is already on dialysis, we need not have to worry. In those cases, we can use the iodinated contrast without any worry. In those group of patients, gadolinium contrasts are contraindicated. Not because it is nephrotoxic, but it causes what is called as nephrogenesis.
Dialysis patients, the gadolinium contrast are
contraindicated.
So with caution, we have to use the.
No, we can use iodinated contrast freely. It won't. There is nothing. Kidney much is left to damage, so we can use the iodinated contrast in those cases.
So in normal CECT abdomen and pelvis, the contrast agent used is less compared to the coronary angiograms.
So conventional angio has got less contrast, but CECT abdomen and all they use more contrast. See, all radiology related procedures they use more contrast. For simple angiogram, the contrast used is less, but the difference is most of the radiology related procedures they use IV contrast. Here they inject intra-arterial. Intra-arterial contrast are slightly more toxic than the intravenous contrast. But amount is more here. That will get balanced.
Okay. This is a good information about contrast agents which people commonly undergo for the diagnostic purposes. And about the next segment, we go on about the preventive aspects, diet and lifestyle about the kidney diseases. Go. Yeah, in this segment, we'll discuss about preventive aspects, diet and lifestyle diseases on kidney health. Yeah, coming to the reversibility. See, in my clinical experience, many people, young people especially, they come with the HbA1c 7.5. With early intervention of a low carb diet, with optimization of proteins, and good lifestyle and exercise, many of them brought their HbA1c to normal within few months. Similarly, can we reverse a early kidney disease also?
Okay. Now, as I mentioned, very early in the course, when the proteinuria is in the microalbuminuric range, with lifestyle modifications and correction of the risk factors, we can reverse the process. But once overt albuminuria, that is more than 300 milligram of proteinuria or albuminuria is seen, the chances of reversal is less. It is a progressive disease, not a regressive disease. It progresses over a period of time. Having said that, how to slow down the progression is what is important here. In that, first you need to correct the risk factors. Risk factors, the most important being diabetes. If you have diabetes, meet the physician regularly, keep the HbA1c less than 7. That is one. Second, if you are having hypertension, keep it less than 130, 80 is preferable, at least 140, 90. Less than that is ideal. Third, certain medications which can slow down the progression of the kidney disease, like in the initial stages, telmisartan, olmesartan, SGLT2 inhibitors, and there are few other newer drugs which can also help in slowing down the progression of the disease. I'll come to the diet later, that is the most important thing. Other things is like lifestyle modifications. If you have any habits, quit smoking, moderation in alcohol amount, regular exercise at least 30 minutes per day or 45 minutes per day, periodic checking of the kidney function test is of importance. If you are obese, you reduce the weight, because these are all the risk factors for progression of the kidney disease. Most importantly, avoid medicines which can cause damage to the kidneys, especially painkillers and alternative medicine. Diet becomes
So
the
before going to the diet, I have one more question. You said that when patient is having early proteinuria, it can be reversible. Somebody's like a common question is somebody is already having a creatinine 1.52. Can it be come to normal?
Yeah. See, based on the pathophysiology, the early manifestation of any kidney disease due to diabetes or hypertension is proteinuria. After proteinuria, then only the creatinine starts rising, the GFR starts falling.